Thank you.
Very informative session today. Thank you very much for your time. I have a tons of. I'm an engineer by profession, and I've been reading about heart and all kinds of ways to improve my heart. Given the fact that we are in the demographics, South Asians with my family, my uncles, my dad, they all passed away very young. So
Yeah.
so I have to be alert of this. So I have a few things. One thing related to exercise and production of nitric oxide in the endothelium of our arteries and veins. So exercise, I just want to kind of very briefly you discuss the benefits of that. The other thing, the sorry, there's about three questions I have. The other thing is ultrasound of vascular of the heart, echocardiogram, and of your carotid arteries for stroke. That's number two. And number three is ECG using iWatch, because I can run now my ECGs. Well, I'm not a professional, but I can do the ECGs, and it can give me a sense whether my ECG is good or not. Given the fact that atrial fibrillation is one of the highest causes of heart problems in the Western countries. So if you can just discuss those, I'd appreciate it. Thank you.
Uh, Karim, I must tell you, those are very sophisticated questions. I'm very impressed with you. You probably know more than quite a few cardiologists, that's for sure. Anyway, let's deal with the exercise thing. When you exercise, your arteries have to dilate, have to open up, and the arteries have muscle in them. So the muscle relaxes, and so more blood can flow through. So you have a coronary artery, which at baseline and you are resting is 2 millimeters in diameter. Now you start to run or exercise or do some activity, it now needs more blood. And if there is no blockage or plaque or something, it will dilate up to 3-4 millimeters, and much more blood will go through it. So this dilation of the artery by impacting on that muscle is very important. We now term it vasodilatation. But what happens during exercise, the lining of the artery is an active cell. Those cells are very metabolically active. They produce a hormone called EDRF, endothelial derived relaxing factor. And that is what dilates the artery. And so exercise is one of those things that produces EDRF and you dilate the artery. I'm getting to nitric oxide, don't worry. So if you have high cholesterol, or if you have blood sugar problems, or if you have high blood pressure, even if you exercise, the endothelium, the lining of the artery, does not produce EDRF.
Oh,
And so you can't get the full benefit of the exercise.
okay.
And the person who found and did all this science of detecting EDRF actually then found out for himself, which he didn't know, that that is nitric oxide.
Ah,
So what we used to call EDRF is really production of nitric oxide, laughing gas. So
okay.
we do use it in the operating room many times when we want to dilate the arteries of the lungs and drop the pressure in the lungs to give us safety while I'm operating on the right side of the heart and trying to close a hole in the heart or something, but I don't want the pressure in the lungs to cause trouble for me immediately after the surgery, and we'll give them inhalation of laughing gas, which is nitric oxide. All right, so ultrasound of the heart versus ultrasound of the carotid arteries. I told you that this atherosclerotic process, this hardening of the arteries occurs everywhere in the body.
Right.
And different cultural groups get it more in one place than in others. So we can get it in the arteries of the head and neck. We can get it in the arteries of the chest and the aorta and the heart. We can get it in the arteries of the kidney. We can get it in the arteries of the legs. South Asians primarily get it in the arteries of the heart.
Okay.
Japanese get it more in the arteries of the head and neck, and therefore they have more stroke. Whites get it not only in their heart, but they get it in the arteries of the legs as well, and they get more claudication and gangrene and all that stuff. Unless the South Asian is diabetic, then they will get it in the heart and in the legs. So, in order to detect this hardening of the arteries, you want to do imaging that will show you the wall of the artery, right? So you could do an angiogram and it shows that the artery is narrowed, but it's not showing you the wall of the angiogram, it's showing you the lumen. So it is an inference that there is a plaque and a blockage in the wall that's narrowing the artery. So the angiogram is an image of the lumen of the artery, but not of the wall of the artery. When you do an ultrasound, you can get to see the whole artery by ultrasound, and you can see the outer layer of the artery, the middle muscular layer, and the endothelial layer, and you can see if there's plaque buildup in the artery or not. But the artery has to be close enough to the transducer of the machine that you're using to do the ultrasound. So if you use the transducer on the arteries of the heart, first of all, they are very thin, very narrow, 2 millimeters or less are the arteries of the heart on which we work to do the bypass or put the stent in and open that. So if you look at your fist and you look at these vessels on the surface, we are dealing with those inside your heart from 100 centimeters away from a catheter in your wrist or your groin. That's why we get paid the big bucks. Anyway, so the artery has to be close enough to the transducer. So we can't see the heart arteries clearly with an echocardiogram or an ultrasound scan of the heart, but you can see the various other structures of the heart, such as mitral valve and the mitral regurgitation and the muscle of the heart and all that kind of stuff. But the arteries of the head and neck are right here in your neck, just underneath the skin. The carotid artery is right there. So we can use a 10 megahertz transducer, which gives us extremely high definition, and it doesn't have to penetrate deep enough. And we can then now see the artery of the head and neck, the carotid artery, and we can tell if there is plaque developing, the artery wall is thickening, not. So we can detect this problem early on. The problem in South Asians is it may look good and you could have terrible trouble in your heart. So that's the problem. So a carotid ultrasound is a good test. We now call it carotid intimal media thickness assessment, CIMT, and it's a good secondary level test, but I don't think it's as good as a CT angiogram. So the third thing is the ECG of your watch. The ECG of your watch is a great idea for people who have rhythm problems, particularly atrial fibrillation, because it tells you when you are in atrial fibrillation, when you are not, how high your heart rate is going, this, that. But it does not have capability at the moment to detect whether you're having lack of oxygen in your heart. That requires a different kind of equipment, different kind of filter system on the ECG electrical signal to give you whether there is ST segment change and it implies ischemia or lack of oxygen. The watch ECG does not give you that information. So the watch ECG is excellent for electrical rhythm problems of the heart. It's not good for plumbing problems or pump problems of the heart.
Oh, okay. Okay. Thank you.